So let's talk about another nutritional anemia, folic acid deficiency. Folic acid is actually also a B vitamin. It's vitamin B9. It is essential for cell division. So lack of vitamin B9 or folic acid is going to lead to a folic acid deficiency anemia. So this can happen from decreased intake of folate, and that can happen for a couple of different reasons. Our risk factors would be older adults who just aren't eating enough, chronic illnesses such as kidney failure, for example. Alcohol abuse is a huge reason for this. Alcohol abuse has a lot of different reasons why this would put the person at risk for folic acid deficiency. One is that a lot of people with alcohol abuse don't eat enough, right? They take a lot of calories in from the alcohol, but they're not usually on a very nutritious diet. Alcohol actually impairs the absorption of folic acid. If there's liver damage, there's going to be reduced in uptake of vitamin B9. And alcohol increases the excretion of vitamin B9 through the kidneys. So all of that is going to have a really compounding effect, and they're going to be severely deficient in this. And then crash dieting. Crash diets can also impair intake of vitamin B9. So clinical manifestations, your classic anemia symptoms. They're also going to be at a increased risk for bleeding. Folic acid, because it is crucial for cell division, and not only red blood cells but also platelets. So because there are less platelets, there's going to be an increased risk for bleeding. And then long-term confusion, because there's going to be neurological problems too because of the lack of cell division, inability for those cells to divide. So we're going to diagnose this through a CBC, and then we can also do a serum folate. So that'll give us a pretty accurate reading and let us know. Our treatment is going to increase the oral intake of vitamin B9, which is also called folate, which is also called folic acid. So that, lots of terms for the same thing. So that's a little bit confusing. This can be through fortified cereals is a great way. You can also take supplements. Supplements are really important, especially for pregnant women, because the lack of folic acid has been shown to cause a lot of birth defects in pregnancy. So we want to make sure, definitely, if they're pregnant, they're taking those prenatal vitamins. And then there's some complications, confusion because of those long-term neurological defects and disorientation. That's going to lead to a lot of problems like falling. There may be some developmental delays if they're not getting enough of this through their childhood. And then, like I said, those birth defects, like spina bifida is a big one. Now that we know that this can lead to spina bifida, and we try to make sure that pregnant women are taking their prenatal vitamins, and that's really led to a big decrease in the incidence of spina bifida, more modern times, anencephaly, and then cleft lip or palate. So sickle cell anemia is a completely different kind of anemia. This is a type of deformed cell. So the cells become like sickles. They look like C's instead of O's. It is an inherited disorder. There are a lot of carriers in the U.S., but there's only about 72,000 actual cases. And that is because both parents have to be carriers in order for the person to develop this. So like I said, those cells become sickled, meaning they take on like a C shape. They're also very stiff. They lose their flexibility, and they cannot carry that hemoglobin on top of the cell because of that deformed shape. And they also tend to lyse. So this can also become like a hemolytic anemia, because they tend to split open. So there's a couple different reasons for the anemia. Those abnormal cells can't carry the oxygen, but also those cells tend to lyse. So because they of that abnormal shape, they tend to cluster together and form thrombi, and that also forms, it's almost like a clot. So it impairs blood flow. So there's a lot of different problems happening with this type of anemia, and a lot of things we have to think about. So like I said, both parents have to be carriers, and then if both parents are carriers, even if they're unaffected carriers, there's still a 1 in 4 chance that that child is going to have sickle cell anemia. Some clinical manifestations, your classic signs of anemia, but then also the vaso-occlusion and thrombi is going to lead to a lot of pain, especially in hands and feet because of those small blood vessels. That's where those red blood cells get trapped and form those thrombi. They may end up with jaundice just because of all of those lysed cells. They end up in the spleen, and then it causes a buildup of bilirubin, and they become jaundiced. And they may develop fever if there's any kind of infection going on. They're also going to have a lot of other problems like ischemic joints, ischemic organs. It eventually can lead to death. And this is very, very painful when they're in a crisis where they, maybe because they're dehydrated or because they have an illness and they don't have enough fluid, so they have, because of that less fluid, there's less volume, and that's when those cells can cluster and cause those thrombi to happen. So our big hope here and what we're working towards is to prevent those crises from happening. I'm going to diagnose this by looking at the hemoglobin level. It's going to be low because of the lysis and because of the inability of those sickled cells to hold that hemoglobin. And then we can also check bilirubin levels. We can do a lot of genetic testing too to see if this person is a carrier of that sickle cell trait. So treatment, especially if they're in a crisis, is to give them oxygen, really aggressive hydration, because we want to increase the volume so that there's more ability for those cells to move freely and that they're not getting clustered. We really need to give them a lot of really good pain medication because, like I said, this is extremely painful. So we're talking opioid pain management, not ibuprofen pain management. And then if they have a fever, then we're going to need to give them some antipyretics. So complications would be acute chest syndrome. This is when those old cells or those sickled cells clump together in the lungs, and that can lead to a lot of respiratory issues. So that's when we really need to make sure they're getting enough oxygen, because already they're not have enough oxygen on board because those cells can't hold that hemoglobin, and now all those cells are clustering in the lungs, so it can really become a big problem. Because of the thrombi, they're going to be at risk for CVA and infection because of those thrombi. Developmental delay just from the lack of oxygen. Disability. This can lead to a lot of complications in pregnancy. And then hand-foot syndrome is when those cells cluster in those small vessels of the hands and the feet, and they become really swollen and extremely painful. And a lot of times that's our first sign that they're in a crisis. Aplastic anemia is very different. This is, if you remember, whenever you see that A in front of a term, it means lack of or none. So like anemia means lack of red blood cells. Aplastic means we're not producing. So there's something wrong with the bone marrow that is causing it to not produce red blood cells or just not produce enough. So this happens equally in males and females. A lot more incidence of this than sickle cell anemia, for example. This could be damage to the bone marrow or just decreased production of bone marrow or bone marrow products like red blood cells. But if there's a decrease in red blood cell production, think about it, there's also probably going to be a decrease in white blood cells, platelet counts. So this is going to cause something called pancytopenia, where we see a combination of anemia, leukopenia, and thrombocytopenia. So that's called pancytopenia. The whole thing is going to be low. So because of that, we're going to see not just symptoms of anemia, but we're also going to see symptoms of leukopenia. So just think about your risk factors there. Somebody that has an immune system that's not functioning well because of infection, HIV, or maybe autoimmune disorder, and where they're immunosuppressed. This can also come from chemical exposure or chemotherapy. And chemotherapy, this is kind of like an expected thing to occur. We're purposefully suppressing the immune system with that chemotherapy and causing those cells to stop dividing, but it is going to cause an aplastic anemia in whoever's getting chemotherapy. So like I said, classic symptoms of anemia, but then also symptoms of leukopenia, so they're going to be more susceptible to infections, and the thrombocytopenia, so they're going to be at an increased risk for bleeding. We can diagnose this through our CBC and coagulation studies because they're going to have also the thrombocytopenia, and then we can also do a bone marrow biopsy. That's going to be our definitive diagnosis. So treatment for this is a little difficult. They may need a blood transfusion if they're severely anemic, or possibly even a bone marrow transplant. We can give filgrastim, which is a colony-stimulating factor, which is going to hopefully help their body produce more of their own white blood cells. And then epoetin alpha, sometimes it's just called epoetin, is a medication we can give. It's also a colony-stimulating factor to increase their own production of red blood cells. Probably going to need oxygen, and then depending on how thrombocytopenic they become, usually if it's less than 50,000, we're probably going to end up putting them on bleeding precautions. Neutropenic precautions, again, maybe not, but we're going to look at that white blood cell count. If it's less than 2, probably definitely if it's less than 1, we're going to start thinking about putting them on neutropenic precautions, which is also called reverse isolation or protective precautions. And then complications, we need to think about the effects of the anemia, leukopenia, and thrombocytopenia. The thrombocytopenia, if it gets severe enough, can cause a hemorrhage, and this is a hemorrhage in somebody that's already anemic, so that's going to be pretty severe. Worry about severe infection, and then if they get a bone marrow transplant, then they may develop graft versus host, where the body is rejecting that transplant. So mortality is pretty high on somebody with aplastic anemia. So this is something that we're really going to have to keep a close eye on.